This is Frontline host Ryan Stanton. Before we get into today's episode, I wanted to invite all of our listeners to join me in Chicago this October for the 2026 ACEP Scientific Assembly. Alone, we each take care of our patients, but together, we can change the face of emergency medicine. Join me and thousands of your colleagues for ACEP 26. Register now at acep.org/ACEP26 and get free access to ACEP anytime. We'll see you in Chicago. Ryan Stanton here with ACEP Frontline, and today we're talking a little bit of whole blood, some of the programs popping up all over the country, and today from Colorado chapter of the American College of Emergency Physicians, the 4th Annual Emergency Medicine High Risk Do Not Miss Conference, and talking with the Dr. Scott Branney on pre-hospital whole blood, overcoming barriers and exploiting opportunities. Colorado actually has one of the larger programs in the country right now. My area where I work, the region where I work, just put together a program about a year ago as well. So great opportunities to get whole blood to the patients at their location in time of need. So it's time to join Dr. Scott Branney with pre-hospital whole blood, overcoming barriers and exploiting opportunities.
As everyone in the room knows, nobody needs to learn from me. Only bad habits. Ta-da. Getting there. 2 tremendous lectures to follow up on. So picture me as comic relief, whatever. The other one, from anybody who knows me, my usual thought for this is, wow, I got 30 minutes. I'll start with 60 slides and whittle it down. I tried to do the opposite this time, so deliberately the slide set might be smaller than I'm used to functioning or flying with. So there should be plenty of time for questions, whether it's as something comes up or at the end, please. The other thing is that there's no way to cover this, just so we know. So this is a little bit different than the quality of the presentation I think you guys have just received. But what I want to go over with you is that basically my role in coming to you today is, and for anybody who doesn't know this, never form a coalition, ever, ever. Definitely do not do it after good beer, sitting in a airport bar going, we could do this. This makes sense. We could do this, because it will come back to bite you. So I am a small cog in a very big machine in terms of the Colorado Whole Blood Coalition. We're about 2.5 years old now. We have been working basically after seeing some of the best practices of other pre-hospital whole blood programs in the country, trying to bring this to Colorado. And we decided, well, if we're going to take one bite at this, let's do the whole thing. The program we were looking at was covering 25,000 square miles. We thought, Colorado's only 100. How much difficult could it be? We've now got over 250 members in the coalition. We have excellent representation from our pre-hospital colleagues, from emergency physicians, hospital systems, blood bankers, blood suppliers, a great staff of technical individuals that can do those things of, hey, I need something that can do this. And even better, many people have volunteered that. Hey, I know how to do this. There might be a use for you. Those people are worth their weight in gold. So a lot of multiple content area experts. For anybody who's familiar with STRAC, South Texas Regional Advisory Council, based out of San Antonio, you could make a solid argument that they are the best practice whole blood process in the country. Washington, D.C. will spar with them, and Grady in Atlanta will spar with them a little bit as well. But these guys are now over 10 years into this process. They've given over 1,400 units of pre-hospital whole blood. They've rotated over 10,000 units through their collection and rotation system to minimize waste, and we'll talk about that. And the last thing is we've been pretty busy, so there's a lot going on even at the moment. I've got to update 2 of my slides. I'm going to apologize even from yesterday, where we now got a few changes. This is what really is guiding what's going on. All of us who were taught about the golden hour, it's dead, long gone. What we know in the United States is that the average person, let's back up a bit, the #1 cause of death from birth to age 46 is preventable hemorrhage. So this is a massive cause of death. What we also know is that the average individual who is going to bleed to death will do so between 16 and 34 minutes of their trauma. They're dead by the time they get to the hospital if you wait for more than 30 minutes to initiate stuff. And so with that, another one that comes up, delightful NHTSA cranks out stats like they're going out of style. I will watch my mouth, I'm sorry. But NHTSA has cranked out the stat that of these people who die in that initial window, 40% are alive and talking when paramedics make contact with them. So they are in the process of death if we can somehow intervene and interrupt that before we get to the hospital. But it just doesn't work to wait till we get to the hospital. Everybody knows, no matter how good your system is, how fast can you spin something up when somebody arrives in one of your major trauma bays. This study was actually done, Dr. Stacy Shackelford, who was in the military when she did this, born and raised in Colorado. It's out of JAMA Surgery from 2016. She is a rock star in this. She was the first to actually demonstrate in Western Afghanistan that if you can somehow get blood on board to somebody within the first 34 minutes, you have a 6-fold initial increase in survival and a 3-fold initial or final increase in survival at 28 days. Number needed to treat is 6. This is our process, what we're trying to basically mimic in a civilian setting in the United States. Our model in Colorado will probably have some similarity to this, but you're going to have a number of individuals who love to come with, hey, my EMS system is so good, I don't need to worry about this. Our transport times are 7 to 8 minutes. We've got them into the trauma bays. Absolutely not enough time to do this. Juan Duchesne and the group out of Tulane in New Orleans basically found that they add 3 minutes to their scene time and transport time by initiating whole blood pre-hospital. They get blood on board 12 minutes faster than if they wait to do the exact same thing. Cooler of blood waiting in the trauma bay at their major facilities. And they dropped again another 3-fold decrease, 29% mortality to 7%. Caveat to this, urban model, 75% truncal GSWs. These people are sick as snot that they're working with. The other one they also found is that you have an 11% increase in mortality every minute that a paramedic is with the patient and has not initiated blood. This has actually been borne out in some other systems. San Antonio, basically, if you don't have blood within 29 minutes of patient contact, their mortality is 100%. And it is absolutely linear going backwards beyond that. So we know as our medics make contact, the whole goal is to try and get blood on as quickly as we can. This is the current map that we look at. There's 300 plus agencies in the United States that could be carrying whole blood. Less than 3% do currently. We don't have a bad representation, and this one's not as good as it should be. Very important one sitting down there in Gunnison is one of the OG groups from this standpoint within this state and otherwise. I'll show you our map in a moment, but notice the paucity of stuff geographically. This is a whole bunch easier to do if I've got an urban setting or if my suburban model is basically cranked in right around it. What we are trying to do with our regional setting really is somewhat novel in terms of how things are going across the country. This is one of the slides I actually need to change. First and foremost, for my helicopter emergency medicine people in the room, this is mine, throw stones at me later. What I tried to do was take each of these circles as a 50-mile radius sitting around a helicopter base. So if somebody says, we got to go now, I run out, spin the rotors up, how fast can I get or how far can I get in 30 minutes? But what this shows is that optimally, if we have flying weather, which I can tell you in this section, we have basically about 40% of our days each year are non-flyable. Not always snow, oftentimes wind. And especially when we start talking about aircraft crossing the Continental Divide. Yesterday afternoon, Alamosa added to this, so they'll now have a similar coverage from that standpoint. It's actually in the ED, but they have to walk through the ED to get to the elevator to go to the helipad. So we'll be adding those in, and then Salida is pretty much in the bucket for the same thing. They're just not there yet. One of the things that's too important with this, when we look at our rural setting, this works really well unless you're on the eastern or southeastern corner of the state, or in your northwestern corner of the state. Guess which areas of the state also do not have adequate paramedic coverage? Those same areas. You know what I mean? Now on the flip side, much like in Texas, you got to make certain the helicopters don't bump into one another on the front range. Texas actually maintains 4 times the helicopter density we have. The other one is they have less than 30 non-flyable days a year. So their model for the rural solution is we just throw helicopters at it. And it works reasonably well for them. Their ability to get blood on scene to the extreme rural settings is facilitated by basically 4 times as many aircraft. As you can see, most of our aircraft carrying whole blood, combination of liquid plasma. We have one agency that basically is packed red blood cells and plasma. Plasma, again, being a preferred product over packed red blood cells. We look at our hierarchy of whole blood, then plasma, then packed red blood cells. A lot of our really significant hemorrhagic shocks still have hemoglobin somewhere in the 8 to 9 range. You know what I mean? There's enough hemoglobin. The problem is it's leaking out through all the holes secondary to traumatic-induced coagulopathy. This is our current model. I should say current. It will be as of December 1 for 4 of these units here, including Summit County. We've got 21 different units with 14 different agencies. Colorado Springs was kind of the first, I shouldn't say that. Gunnison was the first agency in the state to get stuff going. Colorado Springs has 2 units in urban Colorado Springs. They were one of the initial big groups to do this. They followed the STRAC model as well from Texas. They're now a little over 200 units they've administered. And tremendous success rate from that standpoint. Pueblo has been up for now a little over 4.5 weeks, and they've given 10 units of blood already. They're rocking. When you think of urban areas, it's pretty comparable in terms of things. The absolute best in the country, or if you want to say best in the terms of blood utilization, Washington, D.C. gives a unit of blood every 19 hours. Grady gives one every 11 hours. They don't have to rotate it. They get it in the ambulance, it's done in the same day, whereas for a lot of our standpoint, we have units that go out into the field. If they're not used, we then rotate them back to one of our trauma centers with some life expectancy left on that unit of blood so that it can get used before it goes to waste. Problem right now in Colorado, at least for the next little bit, all of this is 21-day blood as well. We get the blood 3 to 4 days after it's been collected, shipped directly in most places in Colorado directly to the agency. Agency keeps it for a week. They then rotate it back to a trauma center with somewhere in 9 to 10 days to use before it has to go in the trash. Texas is the benchmark in that their waste is under 2%. Right now, statewide for us, again, none of this is older than basically a year and a half. We're right about 18 for the most part. I'd be tough, we're still siloing some of that out as to exact numbers. But with this, these are the areas we're looking at. We've got some basically in the urban setting. We've got more coming Denver Metro. Basically, Loveland is where most of this is actually stored up here, but goes up into Fort Collins. Pueblo's got stuff going, and then again, we've got the I-70 corridor pretty well covered now. As of December 1, we'll basically have blood from the foothills basically just west of Denver, so basically Red Rocks level, if you think, that's where Highlands Rescues area basically starts, all the way to Gypsum basically just before you get to Glenwood Canyon. So the units that are coming online are basically going to be in Summit, Frisco, and then Clear Creek has 2, Highland has 1, couple up in Grand County. Those are the ones I'm most closely affiliated with because that's where my medical direction lies, right up front. By next year, we anticipate, sorry, I didn't get my switch. Probably 30 units we anticipate by the end of next year, or at least mid to end, starting to add more to the western slope, which obviously presents its own challenges in that regard. Then starting to get some stuff going with Anschutz to start pushing this east as well. One of the complications with this is you have to have rotation centers using whole blood. I'm spoiled, I've got St. Anthony's. Every mass transfusion protocol unit, so every emergent release unit at St. Anthony's is whole blood. Don't use pack cells, don't use components. You can do that, the old 1:1:1 or 1:1:2, whatever your favorite flavor is, but you have to have facilities dedicated to basically using whole blood so you can rotate it through the field and have reservoirs coming back in.
Is that one of the biggest contributors to higher percentage of waste?
Yes. One of it is that. The other one is if they'd go to a 35-day product instead of a 21, which unfortunately means we also go to a non-leuko-reduced blood product, which for anyone who knows blood bankers, as soon as you try and take one of those little pieces out, palpitations sort of begin, then the active chest pain. but it's a little bit of a balance. What product are we using? The 21-day leukoreduced, as we are using now, is the absolute safest. That's exactly what every blood bank has used for the last 10 to 15 years, unless you live in Texas, and a few other select spots. We're transitioning to that. We're starting to make efforts to actually move towards a longer lifespan product so you can rotate it more of it out in the field. What I wanted to cover with the guys going forward was kind of a couple of the big challenges we've got. And first, one of the problems we did when we were writing on the back of our little envelope was, how do we do this equitably? Easy if you're living, in an area where you've got a major trauma center in your city and you're not that far from it. Little bit different if I'm living out in Yuma or Lamar or Springfield on the eastern slope. We look at a number of these facilities. Lack of actual donor data, we'll talk about a bit, and then unified data collection are a couple of the big challenges. So when we look at Colorado, I guess I looked at the bright side of this. 15% of the patients of this state's population doesn't live inside that box. We have 5.9 million people. I've got 900,000 outside the box and 5 million inside the box. Obviously, a lot of resources needed to support that, both from an urban and suburban standpoint, but we start looking at how do we address all of these outside facilities geographically and in terms of capability. There's 30,000 square miles of our state that do not have ALS coverage in terms of paramedics, period. They're going to be basically EMTs or volunteers. Numerous facilities that do not have ALS services bringing them any traffic at all. So we're trying to address, how do we help those individuals? Part of this is we are making a little bit of a transition this year. So the whole blood is the gold standard of how to resuscitate people. We've seen from the military data and from civilian data, this is the best way to reduce death in the pre-hospital setting. It'll reduce your mortality and hemorrhagic shock by 50%. But what we've also found, if I can't get it, the next best thing in line is probably to have plasma administered. I get all of the coagulopathic treatments, you know what I mean? I'm getting all the clotting factors. I'm helping shut down that coagulopathy. Only problem is I don't have any hemoglobin. There's got to be enough hemoglobin there to keep the system alive till we can add that in. But this may be able to serve as a bridge to, I'm in a rural area, I have plasma administered because I don't have to rotate that. One of the things we've stressed already is trying to reduce our waste by rotating whole blood back. Blood banks don't care anything about liquid plasma. You can get it for 26 days. If you don't use it, pitch it in the trash at the end. They pay people for it. You know what I mean? There's truly a surplus of that product. The waste still bugs me in that regard. It's something that seems like it should be more precious than it seems to be perceived, but truly that's the way they come across. And the other we know is that if I'm giving my rural and frontier paramedics and EMTs a fluid to give, everybody in this room, I'm hoping, is already familiar with how bad crystalloids are for individuals, particularly if they're in hemorrhagic shock. Normal saline particularly, it's acidotic. It's going to basically worsen my coagulopathy. I can come up with just a list of why it is not good, all of which gets replaced if we go to plasma. So if I use plasma instead of crystalloids for volume resuscitation and hemorrhagic shock, it's not a bad volume expander. It doesn't leak out of the system. Has chock full of those delightful little coagulation proteins that are going to help me out from my coagulopathy. And so we're actually looking towards trying to put protocols in place via our little CP3 program to basically do as much replacement of crystalloid resuscitation with plasma-based as we can. Had a plus-minus day over at the MPAC meeting, on that little meeting going on east of here, in the last day or two trying to switch policy. But what we know is something you guys all know in terms of resuscitation already. Edema is not your friend. When we start thinking about the burn patients, we blow up with 5 liters of fluid, have to intubate them before I lose the airway that I'm damaging by giving fluid. So we know that plasma does great for burns. There's actually great animal models for sepsis. Because again, I'm resuscitating without necessarily creating that interstitial edema as a side effect of what we're trying to do. So we're trying to get this part of things incorporated. And then the other one I'll point out, it's great for treating traumatic brain injury. Anybody who's not really familiar with the Pamper study that was in the New England Journal of Medicine, This was basically all aeromedical services looking at the benefits of plasma in terms of reducing mortality from both hemorrhagic shock and traumatic brain injury. So it's about 35% in terms of hemorrhagic shock, but if you pull the severe, well, I shouldn't say severely, moderate to severe brain injury individuals out, Glasgow less than 12, increase their survivability by 45%. Because again, you're not causing brain edema as a secondary injury. That's the benefit to it as we look at it. So, oh crap, what did I do? And I guarantee, however your conference goes, I will be the hack, just so we all know in terms of computer skills. So, one of the other things we're also looking at for our rural process is, do we institute a walking blood bank? If I don't have blood that I can rotate to somebody, if I've got pre-screened volunteers that have been tested, fully donor tested within a reasonable time frame, we just go, okay, this isn't great. I'd love to actually get you a truly tested unit. I'm going to have to take your word that your last time donation or donating was 6 months ago, 6 weeks ago. We're wrestling with that number, but that it's better than having an increase of your mortality by 50%. We should just give you warm person-to-person transfusion. That causes a lot of angst for a lot of different people, as I learned over the last several days. It can be done, but it's completely outside of most of you people who are, anybody who's doing EMS medical direction. It's all on the director. I can't say that, hey, I've got a transfusion service at St. Anthony's that would like to do warm person-to-person. It doesn't fly that way. FDA will chew that up. But if you decide the risk of my patient bleeding to death is sufficient and I have no other good alternative, a medical director can put a program in place like this. All right, that's part of our problem. The other one we have is one of the cool things when we look at Texas is they had what was initially the Brothers in Arms program. They rallied a little bit and switched that to actually the Heroes in Arms program to basically get rid of gender discrepancy, particularly as it applies. There are places, many of these programs started with male only. You can basically use women that have been pregnant as long as you ensure that their HLA-1 and HLA-2 are not elevated. That is the big risk for developing transfusion-associated lung injury. So when people talk about trolley mitigation on blood, if we know that someone's HLA-1 and 2 are normal, they're not going to increase that risk of occurrence of that injury. So Texas did this. We have in Colorado one blood supplier that does 93% of the state. Anybody who's familiar with Vitalant? They're nice people. They're a good company. They've been working with us. They will not tell us anything about who our donors are, where the blood goes, how it just falls into this great black box. And the boxes come back out of it with blood. But in Texas, they have the ability to go, they have a tear-jerking video of one of the young ladies who was shot at Uvalde, meeting individually, here's the person who donated the blood. This, you donated unit 1, you donated number 2, you donated number 3, and the amount of the effect that has on the donating community, on that sense of community of everybody blood bank-wise, is not something we have been able to access. So, because your blood might end up in North Dakota, or it's, what I'm saying, there's no direct link in that sense. The other is the blood product that Vitalant chooses to use to make their whole blood for Colorado is only collected at 4 sites in the Denver metro area. So I can have somebody interested in hell in doing this in Steamboat, and they're, Vitalant's happy to take their blood, but cannot guarantee it's going to be part of any, low titer O positive program. And so it's a little bit different. This is also facilitated if you go to a product that doesn't require leukoreduction. I can collect it anywhere, or a system can collect it anywhere. It doesn't have to be located to this. So we are working very diligently on basically trying to put together a system. Picture it as the probably microbrew version of whole blood. And Vitalant is like, I don't know, Coors, Budweiser, whatever, one of the big boys. I use big box, but that tends to piss them off when you tend to call them that too much. But with this, we're trying to figure out how can we get additional participation, sense of community, more information for our donors. We're probably going to have to branch out and do it on our own. Just probably not going to fly otherwise. Sir?
So in the meantime, where would you
recommend people donate blood?
I'd recommend they donate at Vitalant. Any blood is better than no blood. Just this last week, and let me qualify, who's donated to Vitalant? How often does Carol send you a robocall? Damn near every day. Yes, right. And so for a low titer O positive individual, you guys all know this, they're on our case every day. So I still think it's best for the moment, but I think it could be improved on. And when you look at best practice nationally, I think there's a whole lot of improvement, but it does not fit their structure. So they have been a good partner, mostly because they've had to put up with people like me for the last 2.5 years. But in the same time, could they be a better partner? Oh yeah. And hopefully for someone like you're describing, much better if you can go, hey, remember that unit of blood you gave? I'll get you a follow-up text on it. It went to so-and-so. Or unfortunately, oh shit, we wasted that one. We're very sorry, but please come back to us. You know what I mean? But true transparency, a sense of community and cooperation we're lacking at the moment. So that's something we're trying to build. This is also another one this week. Otherwise, I would have had it up on a slide. My most recent message from Vitalant is their whole advertising campaign is, you will never know who received your blood. They will never know that you gave it, but you're doing something good. Well, better. I kind of like the thought of meeting the young lady from Uvalde if I was the one that did that. How often do you think those people are going to donate for the rest of their lives? You know what I mean? I think there's just, again, better way to do it. So we're working on that piece. The other one we're trying to work at, which is actually coming together pretty well also in this year, is there's no standardization in terms of data collection. And we're in the process basically of putting together a standardized data collection set that meets the national needs in terms of NMSIS, all those guys, meets our CDPHE needs, so that everybody's submitting the same data. So then we can start to go, hey, Branney's hospital doesn't do that well in terms of our ability to waste blood. But Dr. Corniss's hospital, oh, cutting edge. You know what I mean? We can start to get feedback within our system of how we start making improvements. We actually are putting together a tracking app that will be able to do this. Blood, when we're rotating in the field, we have to check it every day. At the end of that week of the blood being out in the field, we come back to our blood bankers and go, here's its temperature log, and here's its custody log. We have to be able to demonstrate from the moment it left Vitalant till it gets used, every hand that touched it. At least on I was the one responsible for it that day. It doesn't have to be, micromanaged beyond that. But with this, we can now do all of this off a phone app. Scan the barcode, whoop, it's in my phone, I type it in, Branney took over it today, and when it comes back in 7 days later, all we have to do is show that. The other one, as we start putting this together, we can also identify off this, we've got an app component that allows us to basically show where is every unit of blood in Colorado currently, and basically just bring it up on an ArcGIS screen. So if you're sitting in Yuma, way out at the eastern edge of the state, and I want to get to Memorial in Colorado Springs, who has blood between me and them that I can now contact and say, hey, little mutual aid here. How can we start assisting one another? And this is all coming together pretty much, as I said, right about now. With this, one of the other pieces, this allows, again, I participate in the Foothills RETAC. So if you guys are, I'm hoping everybody's familiar with RETACs in the room. These are basically the 11 areas within Colorado assigned to, I can't even remember what the R is, emergency trauma and care facilities. But basically, they're the ones that do all the coordination. If you're in Gilpin, what trauma center do you go to? Where do you take hands? Where do you take burns? You know what I mean? They do all of that coordination. So this is a graph of the Foothills RETAC since we started whole blood. Pretty much you can see we're all the way back to late December. We had a few, but the ability to come to our partners and be completely transparent of February was really bad. Wasted 8 units. And part of it was just couldn't get more blood, had problems. There wasn't enough being used in the hospital. I don't know whether it's a good month for trauma that none happened or a bad month for trauma that none happened. That was all of a sudden we got a lot of waste. But we're able to basically demonstrate to our partners, here's exactly how much blood we're using and where it's going. The other one, this is the community screen. Anybody in this room could go to the Foothills RETAC right now and pull this up, accurate to today. But also behind it, we now have an Access QC/QI protected screen where you can go to and see, what did Grand County do? How is Clear Creek looking this month? Who do we do mutual aid with? You know what I mean? A full package that will allow us to do accurate QC/QI, and to do this on a both statewide, RETAC-wide, all the way down to agency level in terms of QC/QI. That right now is basically just completing its beta testing, should be fully live and operational by January 1. So where this takes us, remember all those little blood units we had already? Next year, we're talking about 30. We figure our optimal ground map for a state our size is probably 100 to 120 units on the ground. We can support that in terms of our rotation centers, but we also now start looking at what else we can do to add to that. We're going to start adding the question of warm person to person, the kind of walking blood bank type donations, as well as plasma products, whether liquid, or we can sometimes do this with dried plasma if it gets approved in the FDA. But what we're looking at is this giant matrix of different blood products. You might be working in a facility that can't support whole blood, but you might be able to take a long-term storage or use dried plasma, all sorts of different iterations, so that everybody in the state has access to a blood product within that 34-minute window.
How many systems are approved for whole blood? It sounds like university,
Like,
Common Spirit.
like systems or agencies?
I don't.
And
guess like hospital partners that you can hand the blood off to, so it doesn't go to waste.
sure. Right now, probably the biggest ones, HCA is not a big player, I should say, as I start mixing my initials. University, very strong at MCR, huge at Memorial and Colorado Springs. That is one, it's a big fish, but the second, they are cranking stuff through. Common Spirit, predominantly St. Anthony's at the moment, but a lot of plans for expansion to that, to other St. Anthony's facilities. Intermountain, they're now participating as well. Their program with Arvada Fire and Lutheran is just getting started. Excellent, well designed from that standpoint. The other one is at some point down the road, Grand Junction, St. Mary's is another Intermountain facility. They're going to be a bigger player as parts come along. Now, the problem is Denver Health, which please understand, that's still Mecca for me. But with this, trying to get them on board, they largely use Red Cross blood. A system could still be spun up to do this. And in fact, Denver Health is supplying the 2 units of blood that are being used in Eagle County at the moment. So these relationships sometimes are more who you can set up with a program that works. We're still at a small number. Again, probably by the time we're done, 23 aircraft, we'll probably have that, probably about 120 on the ground, and I could see another 100 plus facilities using plasma in some sort, if we're going to accomplish what we want to.
And blood administration like this is mostly in a trauma setting.
No, that's the good
It's
news.
like, because, talk to me more.
Talk to you more. It's a great question. When we look at nationwide data, about 40% is used for non-trauma. 15% is peripartum hemorrhage. So pregnancy-related hemorrhage is a big one. Some of Colorado Springs, again, we know the rules, no anecdotes. But with this, anecdotally, Colorado Springs has had a couple spectacular saves in terms of peripartum hemorrhage. And then the other ones are largely GI bleed. That's our biggest other big blood loss medical category. But 60% is basically coming to us from trauma. Now you got your next question. You're just you're fountain, setting me up here. Because I knew if we got to this question stage, because one of the things I've not brought up, we're offering one product, low titer O positive, no O neg anywhere in here. And so part of that is difficulty. What's our percentage of O neg individuals across the country? 4%. All of that is largely used by inpatient patients. You know what I mean? That there's already a tremendous need for the pool of O negative. So there's no way we could go, we'll only collect from O negative providers. The flip side is 28% of the population is not only O positive, but has low titers of anti-A and anti-B. It's the next best choice. And so as most programs across the country have decided, we're going to administer low titer O positive to all comers, including women of reproductive age, or actually reproductive potential. is something to be very cautious on in that. I don't need reproductive age. I need to think just as strong about this with the 7-year-old who has their whole reproductive life in front of them, even if it hasn't started yet. So, how do we handle this? Two big schools of thought, of which there is not quite unification yet. There's probably a little bit of a trend. University and St. Anthony's, so Common Spirit, have largely looked at this and gone, if I'm giving you a whole unit of whole blood that is mismatched, one, how much ROGAM does it take to fix that? 6 to 9 grams. How much ROGAM does your hospital have? Because what do we give ROGAM for? We give them for little 10 ml post-chorionic bleeds. And all of a sudden, and the other is, what does ROGAM do to abnormal blood cells? Lyses them. So if I give you a unit of whole blood that is mismatched Rh negative and give you ROGAM, the moment I give you the ROGAM, it hemolyzes all of that. The general thought is once, and it's a great sticking point, most of the units of blood we give are going to be single unit. You know what I mean? There's not that many multi-blood units, because the whole goal is I'm not trying to fix you. I'm trying to keep you alive long enough from wherever you are till you get to the surgeon, get to the OBGYN, endoscopist, I guess, in a rare setting. But with this, you know what I'm saying with this? The whole goal is just bridging and improving that shock burden until you can actually get to where it can be addressed. So the problem becomes, if I'm going to a hospital that uses low titer O positive whole blood like St. Anthony's, do I not give you this anymore? If I go back to component therapy, I know the outcome is not as good as using whole blood. If it's like you got O positive in the field, reproductive age woman, I'm going to go and shift back to product. I'm going to increase your mortality just by going to a different product type, even though I'm now better set from a mismatch. So the thought for most agencies, at least locally, is to go ahead and just deal with the consequences down the road. You're going to have about an 8 to 40% chance that those people will alloimmunize. If, you know, an Rh negative woman who receives Rh positive blood, 8 to 40% will immunize. If we take it to the end point of what do I worry about with autoimmunization is hemolytic disease of the newborn. How much blood would I have to give to have one fetal death? And the thoughts of that now vary. There's a new study out from UCLA recently, it's basically, you'd have to have 1 in 10,000 is their mortality rate. Mark Yazer, who's at University of Pittsburgh, is probably the heme god, I think, at least in this particular space. He has it at 3 in 10,000. So and again, hemolytic disease in the newborn is now treatable, difficult. I mean, the thought of doing fetal exchange transfusion via umbilical vein pretty much causes my brain to start seizing a little bit, but apparently not to all of the maternal fetal disease people. You know, it's out there, but it's not as far out as some other things. So that is something that we are well aware of, but when we look at the balance of things, and they've done some studies of like, okay, how big a risk would you have, you know, if we're going to give you this, you're going to convert, you're going to have problems with your next pregnancy. How much of an improvement in your life would it have to be to do this? And most people put it at about 10%. It's like we can reduce your mortality by 50 because we're not doing this for patients that are outside of hemolytic shock. Now, as all you guys know, I'm great for the smart-ass comment, but this one actually comes from elsewhere. Geir Stranding is one of the Norwegian guys who's behind all of this. Complications are for survivors. And if we can get you to the hospital, keep you alive, then we can figure out how to deal with the complication to that. And I will confess that if you picture that bell curve, I'm somewhere out over here on that end of it. But just please be aware of that bias as we discuss it. We have talked about this in rural America with a couple of complications. One is our weather. I have two choices, and the FDA will only permit one of these. Drone has to stop, it cannot land, and it can lower stuff down. There are places in Florida that actually do this. They only have about a 3-mile range. The ones in Africa, they've got over 100-mile range. It's great. I don't know if you've ever seen it. Off it goes. It is. But they basically then, and what's wild is they fly them back. I have no idea how they pull that piece off. But with that topic has come up. And some of our complication is I'm in a motor vehicle accident on I-70 going west, but I'm on the north side of the road. And the drone met its 25-meter capability, but it's on the other side of the river. And so time-wise and delivery-wise, it presents some problems, but it's certainly something that people are looking at. And DARPA's all over this, because if they can send an unmanned vehicle to deliver blood or deliver whatever else they might be doing, that's high on their priority list. But nothing that's in the implementable foreseeable future, but in the long run, absolutely. And I think you'll certainly see, if you could give me I don't know, 300 mile an hour all-weather drone that could just come in and dive bomb and drop off my little package. It's hilarious when you see the ones, because it's like the Florida ones, drone stops, that's on a little cable. Do it down. They can do it with either Narcan or blood. They've used both of them in that delivery system.
Dr. Scott Branney with Pre-Hospital Whole Blood, Overcoming Barriers and Exploiting Opportunities from the 4th Annual Emergency Medicine High Risk Do Not Miss Colorado ACEP Conference at the Park Hyatt Beaver Creek Resort and Spa. This is one coming up in November of this year. Feel free to join us, as I will be there as well as part of this conference and speaking, hopefully with my family, but definitely enjoying the beautiful area that is the Beaver Creek Resort. And feel free to contact me, rstanton@acep.org, rstanton@acep.org, and at Everyday Med on X. Please subscribe to the podcast on your favorite player. Leave us a 5-star review. Feedback is a gift. Until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
Dinger. Quiet place, all
Yeah.
alone. Da, da, da.